Providence Skills time, and I'm Dr. Tsai, showing how to do the Minnesota tube. So I think to begin with is we'll give just a little bit of a talk, is what that would be. So this is on the Minnesota tube. Let's see, in return. Nope, it is a two-ticket row. Okay, so obviously as the Minnesota tube is used as a tamponade, and it's used as a tamponade to places where we can't reach. You can't reach inside the chest. It can also be used for serious uterine bleeding too as well, to really stick it up there and then put a balloon up in that region too as well, but we're not in that direction, so we're in the upper area. Complications of cirrhosis are basically 5 of them: encephalopathy, SBP, renal failure, liver cancer, and then the one we're dealing with is variceal bleed. Approximately variceal bleed is 5 to 15% a year. About a third of them of those varices will bleed, and then a small percentage, 10% or so, we cannot handle with endoscopy, meaning it keeps failing is what that would be, and that's where then this last resort tamponade needs to be placed into. So it is a bridge. It can only be in a person in about 24, 48 hours, because any longer than that, you'll kind of get ischemia because of that pressure that's there. So it's a bridge to either go to transplant, go to TIPS, or have a discussion with the family because of all the chaos of end-of-life care or something of that nature, to at least give them time to think about it. There are 3 different ones if you guys care to do so. I don't know if you're ever going to have testing on it, but basically it started with what's called the Linton tube, and that basically has only one balloon, a gastric balloon. Then they said, well, you know what, we need to have a little bit more to it, so we decided to put an esophageal one, and that's called a Blakemore tube, and that one has only 3 ports, so there's not an aspiration for the esophageal one. Again, like I said, not sure if you guys care, but maybe it's in your tests or something of that nature. And then you got the Minnesota tube, which is the one that has the gastric balloon, the esophageal balloon, and then it has the aspiration ports in both of them. And so, like I said, I looked some stuff up, and it did seem like you guys got tested on it. I'm not sure why. But the Blakemore tube I think of it as like a B. And so a B has 1, 2, 3, so it has 3 ports to it. That's really the main importance. And then the Minnesota tube has 4 ports, because I guess maybe in that, what that would be. Let's see. So in my language, because I like it simple, is a Minnesota tube is, you got the dangly parts right here, which are basically the balloon parts, and then you got the big parts, which are the aspiration parts right here, and they're all labeled too as well, in terms of which one is the stomach balloon, which one's the esophageal balloon, and then the aspiration ones too as well. And so the equipment that I have is basically, you have either a lure lock, but if you have a lure lock, I really only need the Minnesota tube, 1 syringe, 2 clamps, a Sharpie, and then the rest I'm going to jimmy rig in terms of how to find it and go from there, and I'll show you how I do it. So when somebody's bleeding and you can't control it, is you need to then go ahead and do a Minnesota tube onto them, so you can do a tamponade. There's these 2 dangly parts that you have here. One is the stomach balloon, and one is the esophageal balloon. These ports right here are the aspiration ones, which you don't have to deal with at this point. This is the gastric balloon. It fills up 500 cc's. This is the esophageal balloon that you have right here. That majority of times you don't need to inflate with this one. So to first of all start off with, these little trumpets are very hard to take off. They're very tight. And so on a new Minnesota tube, you can just take your fingernail, of course you're all gloved, and you basically just squish it down. You squish it down between the 2, and it takes you maybe about 1 or 2 times around, which would loosen this up enough, we can then pop it out. And if I can have somebody help me with the clamp. So we're going to go ahead and do the stomach balloon first. So what you want to do is you want to evaluate the integrity of the balloon first of all. So you're gonna go ahead. I'm going to put some air into the balloon, and then you're going to have the clamp. So air goes in, clamp, And I'm just gonna put enough air where there's enough of a bulge that I can put underwater, unclamp, clamp. And then you're gonna take this, you're gonna stick it underwater, and you're gonna look for if there's any air bubbles. Air bubbles means there's a leak, you need to get a new Minnesota tube. So this one looks good. We're now gonna go on to the esophageal balloon. Okay. Unclamp. And that's usually one is just good enough. And you take this, you stick it under the water. No bubbles. This one's good to go. Now you're going to be placing it into the patient, so you obviously have to undo this because you don't want to put this into the patient. That's too much. So we'll go with the esophageal balloon first. It doesn't matter which one. So take out the air, clamp, and you want to make sure you get the air out as much as you can. Unclamp and clamp. Then you're going to do the same thing with the stomach balloon. Clamp. Unclamp. Clamp. Oh, it's not working because we don't have a trumpet in there.
I'll put this one in it.
So that one was a good example. It didn't work very well, and so we tried to figure it out, and we found out that there was a conduit that was open, and that's why that balloon was not deflating all the way. So now this one should deflate. And so now these are all, nope, this is not as deflated as it should be, so. Okay, and we're gonna have somebody squeeze that. And we're gonna try to get that air out as much as we can. All right, go ahead and clamp. Let's see where that, there it goes. That would be. You then go ahead and lube this up. The bite block gets taken out of the patient. I find it easier for the bite block to be out. So you lube this up, and then it goes into the patient. So usually it works with like a Maloney. So the fingers, the doctor's fingers goes in, brings the tongue down. This goes down in. They say in the instructions to put it through the nose. I've never seen anybody put it through the nose, and I think you're probably gonna have problems putting it through the nose. I've never done it through the nose, nor have I ever seen it. And then it goes at about the 50 mark right here. So at about the 50 mark, the balloon, the gastric balloon, is now past the esophagus, past the diaphragm. You then go ahead and you blow it up, the gastric balloon. Gastric balloon is this one. Unclamp, and you just put a little bit of air in there, and then you can test the balloon by pulling it up, and you'll feel like a tug, and then you know you're in that area, or you can do an x-ray too as well. So once you know that you're in the proper position, you then blow up the balloon 500 cc's, which 500 cc's is about 10 syringes of this one. So there's a little bit of a syringe you put in here, so you can probably put 9 more in here. If you put an extra syringe, you're not gonna hurt the patient. It's not that big of a deal. The esophageal balloon, you put a little bit of an extra too much, you may have a little bit of an issue. But yeah, so this is 2, clamp. 3, clamp. And talking out loud is good because you always forget. We're at 4. We're at 5, clamp. We're at 6, clamp. We're at 7, clamp. We're at 8, clamp. We're at 9, clamp. We're at 10, clamp. And you saw she waited because you don't want to prematurely unclamp this because then all the air is going to come on out. So here's the balloon that you have in the stomach, and then you go ahead and you pull right here, and then it should tamponade the bleeding vessel that you happen to have. So you mark with a Sharpie at the mouth, at the teeth of where it happens to be stretched at, so that way if it ever moves, you'll know if maybe the integrative balloon has popped, or you're at risk of having the Minnesota tube slip out, is what that would be. Now, you then have to figure out how to take this and tie it to somewhere where you can put a weight to it, so you can continue to tamponade this area that's there. So, someone's holding this, you try to find a tie. You might have a tie in your kit. If not, I've always found just getting all the straps from a gown and putting them together. You'll probably need about 4 or 5 gowns. You then just go ahead and wrap right underneath all the dangly parts a knot, and then you hang it up, and then usually it would be you would be over something, is what that would be. So we're going to have you pretend to be that thing up there, and then you hang it to about a 2-pound pressure, a 2-pound, if you have a weight of 2 pounds, if not, a 1-liter bag is about 2 pounds. Right there. And so usually there's going to be one right above the patient's head. There's going to be one right about the patient's feet. And then you hang the bag about at the patient's feet, and that should give you that pressure that's there. And that's your Minnesota tube.